Okay. All right, we're going to get started with our second session. Our first talk is by the one Dr. Alan Barkin, joining us from all the way from Quebec and from McGill. He is just a pioneer in his own field, and so I think this is great opportunity for us to learn. And he's going to be discussing
optimal URCP.
There you go. You picked it up.
Pancreatic duct access.
All right, take it away.
Good morning, everybody. So, safe and efficient biliary cannulation remains the key, as we all know, to successful ERCP. We saw it yesterday. Along with positioning the ERCP scope, biliary cannulation remains one of the most challenging aspects, not just for trainees, but for trainees as well. And the basic principles are helpful in guiding the novice and, of course, the expert. I think you heard that repeatedly yesterday and even the day before in difficult cases. So we'll try and go over things together. But before we start, I just want to say you saw earlier in this course, excellent presentation by Ryan on this same topic 2 days ago or 3 days ago, for those of you who were here. Amazing illustrative cases that were seen yesterday. And I would also like to highlight this new 6-minute cannulation challenge that was imposed by Shimtaka by session that has already become a classic. I think there'll be a publication on this in a couple of weeks, probably. And it was handled brilliantly. However, I think there's some PTSD treatment that's going to have to follow on that. Okay. So the cannulation, this is sagittal view, just to orient you. Bile duct in green, pancreatic duct in pink. Most commonly, there's a short common channel separated by a septum. The common channel can be, however, longer, and you'll see this as you proceed with the cannulation attempts. And biliary and pancreatic orifices can, in fact, be truly separate, and not all patients read the textbooks. They may not be exactly where they should be. You have to keep that in mind for difficult cases. And finally, anomalous pancreatic biliary union with long common channel and bile duct that originates from the pancreatic itself has clinical implications, as you know, for a number of risks for biliary neoplasms and so on. We won't go into details for that today. Okay, so with regards to the anatomy, you have to be, in order to get into the biliary tree, you need to be within the plane parallel to the surface of the mucosa of the duodenum, and that's important. And of course, you have to, with regards to the pancreatic duct, be more perpendicular in your approach. These need to be complemented in a three-dimensional structure, the dimension in your minds, to actually go ahead and aim for biliary tree 11 to 12 o'clock, and for the pancreatic duct, as we discussed, anywhere from roughly 1 to 4. And all of this while you're stabilizing your duodenoscope and a catheter that needs to be close, preferably, as you heard yesterday repeatedly, below the papilla, so you can benefit from natural curvature of the sphincter tome when you're trying to go into the biliary duct. So some general rules. Certainly when I teach, I say you have to respect the ampulla. It can be your friend, but it can be your big-time enemy. Once you have pancreatitis, we have very little we can do to minimize the severity of the pancreatitis. So you want to avoid it. You have to respect the ampulla at all times. Use the natural curve of the sphincter tome, as we said. Optimize the angle between your catheter and the long axis of the bile duct, particularly for biliary work. And what I suggest sometimes, you think of using your scope as a proximal extension to your catheter. I think you heard this when there was a sphincterotomy being done by torquing the scope, which is certainly the way I do it as well. So something to keep in mind, and avoid repeating the same maneuver many times if unsuccessful. We see this repeatedly, and it's a problem as the tension rises in the room. ERCP is one of the most rewarding, but also frustrating endoscopic procedures. Every patient is different, which is wonderful and extremely challenging, but it's also quite humbling. And you leave your ego outside the room and understand your leadership role in the fluoroscopy suite, especially for tough cases. This is true for biliary cannulation and ERCP in general. This is true for all that you'll do in interventional endoscopy. I think you've seen it and you've heard it repeatedly over the last few days. So with regards to post-ERCP pancreatitis prevention, with regards to cannulation, we favor a guide wire-assisted cannulation because it minimizes the trauma to the papilla and the number of pancreatic duct injections. A meta-analysis suggested that you decrease by half the incidence of post-ERCP pancreatitis by initiating with a guide wire-assisted cannulation approach. Early implementation of alternative techniques, we'll discuss wire to double wire or pre-cut, avoiding the same maneuver will go ahead and decrease by half the incidence of post-ERCP pancreatitis. Although for randomized trials, if you think about it, it's very difficult because there's a lot of bias, because by the time you've started, you've already tried many times just by definition, and it's hard to do randomization to see which is the best. And finally, avoid, as we mentioned, over-aggressive repeated injection of the pancreatic duct, although the occasional whiff is actually not a bad thing if you don't know where you are. I'll show you a video for that. And I know one of the speakers had mentioned that during one of the cases. So if we look at this, the common approach would be to gently probe with a sphinctertome and advance the guide wire once you feel that you're in a position that is reasonable. So you want to position yourself a little bit below the papillae ideally, but at least benefit from the U-shaped upward swing of the sphincterome. And sphincterome probably is the best to start with, and then you proceed with regards to deep cannulation. When you touch the papilla, you let the guide wire do the work afterwards. It can negotiate bends and causes less trauma than the full catheter being probed through. A common approach also is to gently probe with the guide wire. So, sorry, there we go. And you see, you protrude your guide wire a little bit at the level of the ampulla, and then you can use that to try and selectively see if you can actually go ahead and cannulate the bile duct. And then you proceed to advance both your catheter and the guide wire through, as you can see here. So those are the different approaches that you can do. Now, as I mentioned, you should avoid pancreatic opacification. When you look at the studies, it used to be, I don't know if you remember yesterday, you saw there was a picture of an ERCP where you could see the tertiary, quaternary pancreatic ductules and so on. That's the way that pancreatic duct opacification was done. It's obviously not what we do, and so on. So I think a lot of the data came from it was aggressive, repeated, quite significant pancreatic duct opacification. A little bit may not be a bad thing, but obviously we discourage it as a rule. This is a patient who had a previous sphincterotomy, and despite that, trouble getting in. And as you'll see here, you see the guide wire coming back, it was flipping back, and there was issues in actually being able to find the right axis. And then just a tad of, although I wouldn't have injected quite as much as that, it gives you a good idea of where you are. You can probably pull back a little bit on the scope and then go ahead and cannulate up with the guide wire in the bile duct itself. So a little bit can be helpful, but again, a little not significant, and certainly not in every case. Alternative cannulation techniques. So to overcome the pancreatic biliary septum, you have the double wire technique. We've heard about it. We saw it. I'll show you a couple of videos. Guide wire alongside pancreatic stent is also an option, a variation thereof. And then transection of tissues overlying the CBD, which is a pre-cut sphincterotomy with needle knife, either over a stent or freehand. And we'll talk briefly about both the fistulotomy or suprapapillary puncture and the transpancreatic septotomy. So this is illustrating the double guide wire technique. So as you're going ahead and trying to get into the, presumably the biliary tree, the duct of interest, you may end up going into the pancreatic duct. We saw this in a number of cases yesterday. And there are options. You can either come out, try again, or you can benefit from the fact that you actually have the guide wire in the pancreatic duct to help you. In this case here, if you look, the papilla is quite floppy, and it may be very useful to actually stabilize the whole structure by actually having a guide wire in the PD and then proceeding with trying to get biliary cannulation above and beyond it. So this is, you'll see here, going in, thinking it's actually good, but it's PD. And so the idea is then you can actually go ahead and remove it, or you can leave the guide wire in place and then use that. And you can see, although it's hard to see how the papilla is more stabilized. It makes it easier to then go ahead and try and selectively cannulate the bile duct itself. So that's certainly a technique. There is a Cochrane meta-analysis that suggested that it was associated with an increased signal for post-ERCP pancreatitis. However, the update of the meta-analysis did not suggest that. So I think many people use this, and that's fine. And there you can see the selective cannulation successfully. You can also do that along a pancreatic stent that you've put in. So once you've been in pancreatic duct, you could go ahead and put in a pancreatic stent and then use that as your base to go ahead and do the similar type of approach, hopefully stabilize the ampulla so that you can try and selectively cannulate the bile duct, which was done subsequently on this case. There. Okay. So moving on to pre-cut sphincterotomy, let's talk about the transpancreatic septotomy first. So you have here, so this may be helpful in this case. As you can see, You start from the main opening, and you may have gone into the pancreas once, and actually go ahead and proceed by opening the ampulla gradually. So this is, you can do it either freehand with a pre-cut, or you can do it with a sphinctertome, and then move up and gradually see if you can actually find the opening of the biliary tree. You do it slowly, because if you do it fast, you can end up getting to the upper rim, then you get some bleeding, then you're really stuck at that point in time. If you do it slowly, you can go ahead and dissect some tissues and see and actually find the biliary opening and can selectively cannulate it. I actually mentioned this to whoever was at one of the groups in cholangioscopy. This is actually a trick, something that's very useful to know. Have a look at the upper left corner of this. You've been trying, and oh, okay, you couldn't get in. It happens not infrequently. And do not panic. That's actually good, because you then have actually an outbound and a direction for which you can go ahead and start doing that. Do not laugh. It works. Okay. And then if you get panicky and you don't know about this, and actually I didn't know it was called Burdick's technique, but if you don't know about this, you're going to come out and then you can cause more trauma. So it's just suggesting it is actually a tool that you can use to build on when in difficult cannulation. Okay. I just thought I'd show that to you. Fistulotomy or suprapapillary puncture. So this is the other way of proceeding with pre-cut, especially if significant portion of the bile duct is thought to be in a duodenum or bulging, or perhaps if you have an impacted stone at the lower part of the ampulla itself and you can go above it. And the most reasons you fail in this approach is because it's not a deep enough cut, although you start slowly and move into cutting into the muscular layer. So you can see here the kind of bulging papilla that's present here. And going to go ahead and use the pre-cut technique and see if you can not from up down up, but rather up down, and gradually go ahead and dissect the muscle layer and see if you can proceed. And what you're going to see here, I just want to show you, you're going to see the bulging of the actual bile duct that is present in some, and which reflects also the fact that you had such a juicy papilla that is there. And then gradually it's going to open up. And you can go ahead and do the selective cannulation by just expanding that. And there you go. Okay. Diverticulum, it's okay to position the tip of the scope in the tick, but you need to know what you're doing, obviously. 2 devices through 1 scope technique. I actually do not use this, but Joe Elmanser, who was kind enough to give me a number of the videos here, does. I just want to show it to you. Or gastroscope with a clear cap. I won't show you the clear cap. That's, I think most people know. But this is an example. So this is a patient who had a papilla in a tick. They decided to go ahead and try and clip it so that it would evert the papilla in a way that's more accessible. That did not work. They stopped. They came back another day. You can see that they quickly put a guide wire with the firm, non-flexible part first, use that pushing down the clip to help evert the papilla a little bit more and try and selectively cannulate in that area. You need to be careful because obviously you can cause trauma with the rigid part of the guide wire that you've used, and the guide wire that you're using is not the guide wire that you have in the sphinctertome. So there are 2 of them coming through the accessory channel. So that's a variant that I had not used before, just mentioning to you. And finally, difficult pancreatic cannulation. So there are a number of ways to proceed. This is a very useful one. It's the reverse of the double guide wire technique. You can get into the bile duct, but you can't get into PD. Well, okay. So you can put a guide wire in the bile duct and then use that to then proceed and try and guide you for the same principle, although obviously you'll be aiming differently in this case, trying to get into the pancreatic duct subsequently through here. And so you can see that the bile duct has been stabilized at this point. And then by repeated attempts, you can actually go ahead and get selective cannulation. Present small pre-cut that's done over here. And eventually getting in through it. If the clinical setting allows you, you can decide to stop and come back another day. And I think this, respectfully and personally, is an approach that people who work in the community should not be afraid of doing. Of course, if the patient has acute cholangitis, you do not want to do that. But if not, it's not unreasonable, or refer the patient subsequently. Rather than doing everything at the same setting, I think it's an issue to try, especially if you don't feel comfortable. However, if you do that, you obviously have to keep track of your performance, because you can't do it on 50% of the cases, obviously. But I think it's a consideration depending on the clinical case. And before I finish, I just want to go through, there are not a huge amount of societal recommendations, but ESG had some in 16. They define difficult biliary cannulation, and this is arguable, but by more than 5 contacts of the papilla, more than 5 minutes once you actually were positioned in front of the papilla, and more than 1 unintended pancreatic cannulation or opacification, which is a rough definition, but it's a possible one. And I know a number of centers who train trainees actually use these definitions to then proceed and take the scope to move with the staff. Guide wire assisted technique for primary biliary cannulation is recommended for the reasons I've mentioned to you. Pancreatic guide wire assisted biliary cannulation, if multiple PD cannulation has been done, is recommended with a pancreatic prophylactic pancreatic stent insertion. Precut with prophylactic PD stent can be done. They recommended needle knife fistulotomy as the approach, but should be done only in someone who has at least an 80% success rate in cannulation. But pancreatic biliary sphincterotomy can be considered in their recommendations with a small difficult papilla using guide wire in the PD. If periampullary diverticulum and the difficult cannulation, PD stent placement and precut sphincterotomy is what they favored. For cannulation of the minor papilla, guide wire cannulation with or without contrast, sphincterotomy over a plastic stent. And if the procedure is a little bit complicated, secretin, as is often given if it's available to you. Before I finish, I just want to mention to you, artificial intelligence is looking at assessing the papilla to decide on the difficulty of cannulation, the anticipated difficulty of cannulation, and predicting how to proceed. There are some companies that are looking at having real-time feedback to tell you where to go, where you actually see like literally arrows as to where to proceed to do the cannulation, succeed on the cannulation. I was in a group of 30 world experts looking at it. Not one felt that AI would ever help this, because it's such dear to our egos to try and get in that we feel a computer would never be able to help you. But of course it will. What we see with our eyes is exactly what the computer will do. And I anticipate, I don't know how long it would take, but it will at least have a role to play somewhere along the way down the road. So in conclusion, be patient, especially more novice endoscopists. Be humble, even a seasoned veteran endoscopist. Be mindful of an approach that, although systematic, can be tailored on a case-by-case with your growing experience. Be safe. Think of the patient foremost. That's true for everything we do. And if clinically appropriate and feasible, do not hesitate to ask for help or bring the patient back for another day. And I'd like to thank Joel Munzer for a number of the videos that I showed you today. Thank you very much for your attention.
That was wonderful. Thank you, Dr. Barkin. Our next speaker is Dr. Colin Knoll. He's joining us all the way from South Africa, and he's going to be discussing the options for biliary drainage in surgically altered anatomy. So welcome.
Thanks very much. Let's just see, make sure, there we go. Okay, thanks very much, Raj, Sachin, Anna, Mohammed. Thanks for the invitation. So I'm going to briefly in the next 15 minutes just go through options for biliary drainage in surgical altered anatomy. I don't have any financial disclosures related to this talk specifically. So just to mention up front, I think ERCP remains the preferred technique for biliary drainage if amenable to it, and keep that at the forefront. However, there is obviously an increase in prevalence in surgical altered anatomy cases, largely because of our increased incidence and prevalence of bariatric surgery. But we're also having expanding indications with regards to our current pancreatic biliary malignancies. Fortunately, parallel to that is this repertoire that's expanding with regards to options in order to deal with this. I'm not going to go through our repertoire, but just to mention that this is increasing. We obviously have the traditional approaches, and then I think this community is very familiar with the device-assisted enteroscopy approaches. But more recently, the US-guided biliary drainage techniques, and the big sort of interest or benefit of this is that it largely, in a large proportion of cases, negates the underlying surgical altered anatomy. So in general speaking, there are 3 techniques: the US rendezvous technique, the transmural technique, and then the antegrade interventional technique. There is some data on this topic. I think keep in mind, not really, the sample sizes are often quite small and the vast majority of data is retrospective, but we do have some data on this. So I'm just going to try summarize it. So if you look at the enteroscopy assisted approaches, regardless of the underlying modality, more or less, the technical success rate is going to be in the region of 60 to 70%. And that might differ slightly depending on the underlying altered anatomy or the surgical procedure. But keep in mind, it's got a relatively favorable adverse events rate. So complications around 4 to 12%. And the vast majority of these complications are mild. And our very own Raj, in his multi-center experience, published on this. And you can just notice the profile of the complications with enteroscopy-assisted approaches. The Achilles heel to it remains the relatively or proportionally low technical success. And there are a number of reasons to this, but the vast majority of them, almost 75%, are as a result of not being able to reach your papilla or your biliary enteric anastomosis. In contrast, if you look at the more invasive techniques, EUS or our transhepatic route, the PTBD route, again, there's some good data on this. Shadia Sundaram from the Tata Memorial Hospitals published a fantastic paper on this more recently, I think in 2023. And again, just to sort of highlight the general consensus, immediately you'll note that the technical success rate is significantly higher, so around sort of 95%. But keep in mind that this comes with an increase in adverse events or complication profile, with the EUS approach being in the region of 8 to 20% and PTBDs being up to around 30%. And you'll automatically see that the actual complication profile is slightly different. And if you look into this subgroup analysis, the complications are more of a mild to moderate as opposed to enteroscopy assisted, where the vast majority are mild complications. So really, when it comes to a graded approach and how do we sort of approach these, one needs to keep in mind that there is a difference in technical success rate, but at the same effect, side effects or complication rate, with potentially EUS having a similar technical success rate, and that translates into clinical success. I haven't gone into that here, but with the potentially more favorable side effect profile compared to the PTBD or transhepatic route. There are a number of algorithms that look at this, fortunately. Strangely enough, not many of them actually incorporate enteroscopy-assisted approaches into the more invasive techniques like the EUS approaches. So I'm going to try to summarize this. And to do that, I'm going to try sort of make it quite simple. And again, Shadia Sundaram and his group very eloquently subdivided these into two types, type 1 and type 2, really depending on whether or not you have continuity of the gastroduodenum interface. So if you look at the top right-hand picture, so I don't know, I'm not sure I'm going to be able to do the pointer here, but top right-hand picture, a very common procedure, the sleeve gastrectomy. You'll see that although you've had some type of surgery and the anatomy is altered, your actual gastroduodenal interface hasn't been interrupted. Similarly with the Billroth 1 procedure, here you have had an interruption, but you still got gastroduodenal continuity. And I think in these cases, conventional ELCP is the forefront. And if you look at data outside surgical altered anatomy, EUS would probably favor over PTBD here, and we'll go into that a bit more. But this is slightly different to the more heterogeneous group, the type 2. So here, sort of lumped into this group, is any surgical procedure where your gastroduodenal continuity is disrupted. And this, as I mentioned, is a heterogeneous group, and I don't know if we can grade this approach here. And this is where sort of trying to tailor it becomes more important for me. And really, the heterogeneity revolves around the numerous procedures that one can do with regards to reconstruction, your length of the afferent limb, the anastomosis type, the angle of the anastomoses. And it's in this group that ELCP, conventional ELCP, more often than not fails. So we have to have some sort of approach to this. So looking at sort of an approach, trying to put this all together, if we take surgical alternate anatomy. My first sort of part of the algorithm is to subdivide them into type 1 versus type 2, depending on whether or not you've got gastroduodenal continuity. And these are the common procedures that would fall into those groups. Going down the left-hand side, type 1, as mentioned here, you've got no change. I'd really stick to the standard ERCP with the standard side viewing duodenoscope. If you fail, it depends on whether or not you've got an underlying benign indication or malignancy, because that just alters the approach slightly. With regards to benign indication, you really don't want to create a fistulous tract, a permanent fistulous tract, abnormal fistulous tract. So the US rendezvous technique or the anterograde interventional technique is probably the next line. And if that fails, one would go down the percutaneous transhepatic biliary drainage route. In the sense of malignancy, I think this is going to change, and you'll see the only difference really is the US transmural approach in a potentially curative patient. And that's because we don't have data yet to say that the transmural approach doesn't alter our oncological resective field. Having said that, there is early data to suggest that it doesn't. And in my own experience, I don't think it makes much of a difference. So currently, if it's curative, US rendezvous. If that fails, currently it would be PTBD, because we have a lot of data to suggest that that's fine in the setting of oncological resection. But as mentioned, I think US transmural approach will probably bump this in the near future. On the palliative side, really US, regardless of the type of approach, is going to be favorable over the PTBD route. So coming to the more heterogeneous groups, so now type 2, no gastroduodenal continuity. I think you can still consider conventional ERCP if you've got a short afferent limb. And my issue with that is more often than not, you'll speak to your surgeon and they'll say the limb is short. It's less than, it's 80, 100 centimeters. And you go and it's a lot more than that. And it is difficult to be able to accurately sort of assess that intraoperatively. But you can consider conventional ERCP if you think that the afferent limb is short. If not, I still advocate that one would go down the balloon endoscopy-assisted ERCP approach. And that really is on the basis that you've got low complication profile, but keeping in mind that your technical success and clinical success might be slightly lower. If that fails, the next part of the algorithm, if that fails, or during that, it really depends as to whether or not with your balloon enteroscopy-assisted approach, you can reach the papilla, but your cannulation's failed. And that really is in sort of around 10 to 12%, so not a huge group. And I'm going to give you an option here, but it's not something that I advocate, and that Ryan and I've talked about it a little bit. The logistics around it is very difficult. But let's say you reach the papilla, but you can't cannulate. You can assist this with the EOS rendezvous approach, similarly to a PTBD rendezvous approach. More often than not, as I mentioned, the failures as a result of not being able to reach the papilla. Just to mention that the rationale around that is with regards to the rendezvous, it's low adverse and might improve cannulation success. But if you're not able to reach your papilla and your left segment 2-3 intrahepatic duct is accessible, well, then really it comes down for me to breaking these up into two broad categories, depending on the underlying surgical procedure. If they've had a Roux-en-Y, or if they sort of had either Whipple-Borath 2 or Roux-en-Y hepatic jejunostomy. In the case of a Roux-en-Y gastric bypass, I think the next step would be to perform an edge procedure, and you've seen fantastic examples over the last couple of days of this being done. If they come from the Whipple-Borath 2 or Roux-en-Y hepatic jejunostomy group, the next is really to assess the underlying pathology, because if you've got an easy biliary access, small stone, or an uncomplicated stricture, the next would be quite feasibly, and we've shown that you can do this, is a single-stage EUS antegrade interventional approach. If, however, you've got a complex stricture, a big stone, or you fail with the single-stage EUS approach, then to transition to a two-stage EUS antegrade interventional approach. In the case that either your edge or your two-stage antegrade interventional approach has failed, in my opinion, this would then define endoscopic failure. And it's in this group that you would then go for the PTBD approach and antegrade intervention. And we can discuss that. I mean, that's what the data currently suggests. But I think in reality and in practical terms, some of us moved to PTBD a little bit earlier than this. And that similarly applies if you don't have access to your left-sided 2-3 ducts. We are now being able to access the right side of the liver, but I think that is in really sort of specialized units that are comfortable doing that via EUS. So this would be the approach for the moment. And that's really on the basis that your PTBD integrated interventional approach, although has a high technical success rate, is associated with a high adverse events rate compared to your EUS-guided approaches. And in the unlikely event that this fails, one would then go to more invasive surgical options, which would either be the laparoscopic assisted ERCP or the salvage surgery. And again, that's on the basis of high adverse events rates, despite the high or equivocal sort of technical success rate. So then just to summarize sort of the graded approach, I think it's important to understand the surgical reconstruction, specifically with regards to the length of the afferent limb. We know that if the afferent limb is more than 150 centimeters, your technical success rate drops well below 20%. The angle and the number of anastomoses also makes a difference. Tailor your approach to the type of reconstruction, and I've simplified it just into the 2 types, type 1 and type 2, depending on whether or not you've got gastroduodenal continuity. The general principles to take home is that your device-assisted enteroscopy has a lower technical and clinical success rate compared to your more invasive approaches, but has a very favorable side effect profile. And then your more sort of interventional approaches, EUS or transhepatic routes, they have a very high technical success rate and clinical success rate, but come with a higher complication profile. There is a learning curve to all these procedures. So if you take the EUS, and I think this is going to change, if you take EUS, we are now seeing that in high volume centers, our complication rates have dropped well below sort of 6 to 5%. So that might change in the near future as we become more and more comfortable. And then lastly, just utilize your local expertise in your multidisciplinary approach and your multidisciplinary team. And in my opinion, you need to tailor your graded approaches to a pure graded approach. And that's it. Thank you.
That was wonderful. Thank you.
Next, it's my distinct pleasure to invite Sumit Singla to speak on hilar strictures. Sumit is the chief of GI and hepatology at Henry Ford in Detroit. I've known him for quite a while, and I've always appreciated his very thoughtful approach to patients. So I know this is an outstanding talk. I've heard him give it numerous times. Thanks, Sumit.
Thanks, Ryan. I really appreciate the kind introduction. Thank you, guys. I added one thing to my title here from just about an hour ago when I was up here, and that's something I'm very proud of, which is chair of the ASGE Cholangioscopy Special Interest Group. And I will put a plug in for that. This was a luncheon that we held earlier this year. Jen is speaking in the back. Raj is there, a bunch of luminaries. I really encourage you as trainees and as attendings to join. We're trying to put together a quality statement right now on how to approach cholangioscopy specifically. So a lot of good stuff comes from that. Most of all, you get to hang out with people like this. So the value proposition alone is worth it there. So consider joining. This is something that is very near and dear to my heart. As my job has changed over time, I've had to narrow my clinical focus, and I've really narrowed it towards patients with cholangiocarcinoma, hilar strictures. This is pretty much how I spend all of my clinical time, and I spend a lot of time thinking about this. This is a patient that I met during COVID. I remember, when you met people during COVID, you really didn't know what their face looked like. You always imagined what existed below their eyes. And I'll never forget Sean and his voice and what I thought the rest of his face looked like, which I really didn't see until he was asleep with a breathing tube in. He had obstructive jaundice, pruritus, and weight loss. He worked at the post office. He was a huge Lions fan. So every time when we were just getting together, we would just talk about the Lions' ups and downs over time. One thing we talked about earlier, a little harder to read in ultrasound, but for our fellows, we should be very comfortable in looking at MRIs and especially MRCPs. So this is just a sequence, and we'll get a nice big arrow sign in a moment demonstrating a hilar stricture. But I really encourage you, everybody, to look at these images yourself and come up with your own procedural plan. So here you can start to see all of the dilation of the left and right and a clear infiltrative lesion at the hilum there. So with any procedure, when we talked about a bioleak the other day, what are you looking to accomplish? You should know that before you even go consent the patient? What are we looking to do today? And in patients with malignant hilar biliary obstruction, I would say that what we're trying to do is, number one, establish biliary drainage. 1A is obtain a tissue diagnosis, and then depending on where you're at and your algorithm at your institution, to potentially stage the biliary anatomy to determine if surgery is going to be feasible. So I put this as a two-part talk, although with the time, I don't think we're going to get to part two, which is how to drain a hilar stricture. So we'll focus on diagnosis. And the things that I wanted to kind of talk through are EUS and ERCP, how they're complementary, but what to do, sampling modalities that are available during ERCP, and then kind of a broad overview of what's coming, AI and newer technologies. So role of EUS, this was something Ken had pointed out in his dogma talk the other day, the risk of seeding with biopsy for primary lesion, the 83% that develop peritoneal mets. It's interesting that the case series was just so small, so there's still a little bit of eye rolling, although this has been accepted pretty much everywhere that we don't sample a hilar mass. We don't primarily sample a hilar mass with EUS, F, and B unless they're clearly not a surgical transplant candidate. There was a single institution series indicating survival was similar, including curative intent surgery, but really that is not something that you want to go into without a clear discussion. During one of the talks this in the last few days, somebody pointed out that I think it was Eric's talk, very reasonable and appropriate to pass an EUS scope and look for regional lymph nodes. Even if it's not commented upon on CT, you'll be surprised. You may find a lymph node, you target that lymph node, you get a diagnosis of cancer, and it saves you from a lot of other steps during ERCP, which then becomes about draining the patient appropriately. In cutting ahead to my approach, I individualize a plan based on the patient. How you approach a 40-year-old who's otherwise completely healthy may be different than how you approach an 80-year-old. You talk to the patient in advance, communicate with transplant and biliary surgery. We've talked a lot about how we interact with surgery. This is critically important. Also consider the pathway for your patient. There's often downstream referrals, no matter what center you're at. Maybe except for Ryan, there's always a second opinion that is potentially available, and you want to make sure that you're not taking anything off of the table for the patient. So really think about how you're going to sample this patient. This is an older cartoon type of slide, but I like it because of the colors. You think about how do we sample hilar strictures during ERCP, a cytology brush, cheap, easy, fast. Everybody knows how to do it. I always ask our fellows, how many actuations do we have to pass the stricture with to really qualify? I know Raj knows this, but I'll wait till the end for somebody to yell out that number. It has incredibly low sensitivity, even when well done. Fluoroscopy guided biopsy. These are either over-the-wire forceps or, generally speaking, pediatric forceps that are passed alongside a guide wire. I always do this no matter what, if I feel like I can reasonably target the area. Kind of like how maybe the newer generations of endoscopists are less comfortable with plastic stents for cisgastros. I feel that there's probably something about really getting comfortable with blindly passing forceps up to the hilum, that maybe there's a learning curve associated with it and a little bit of discomfort associated with it. So I'd encourage all of you to really take this on and learn how to do this during your fellowship. It will help you with patients in the future. Even with both of those, the pooled sensitivities for brushings and high quality intraductal forceps is still 60 to 70%. We talked about EUS and FNB, how it's well suited for lower tumors or a second approach to a hilar mass that you couldn't get a sample of the first time, or a patient who's not a surgical candidate very clearly, but in all other patients approach with a lot of caution. And then this was something about how mini forceps have kind of, in my opinion, changed the approach to hilar strictures. So this is just a really quick view. When you talk about sensitivity, sorry, forgive the storm that's going on in the background, but this is a clear intraductal mass. Look how big that tissue is. So when you look at endoscopic data, it doesn't necessarily encompass what you're going to experience with your patient, because I can tell you just that one bite was sufficient to diagnose cancer in this patient. On the other hand, if you have more of an infiltrative stricture such as this one, you can see there's some abnormal vasculature. There's extrinsic compression. This is a cholangiocarcinoma growing on the outside of the bile duct. And establishing a diagnosis with intraductal forceps is going to be much more challenging in this type of patient. So apologies, I'll move on from this. How do I approach sampling? And I try to not be dogmatic and think about where you're at, where the patient is at in their journey. Think about the risk of a false negative in that individual patient. If you know the pooled sensitivities for brushings and intraductal forceps are 60 to 70%, think about the patient. Have they already had an ERCP with decompression or conventional sampling techniques at an outside institution? If you're a referral hospital, are they coming from several hours away? So that can make, getting a false negative again that much less appealing. I generally think more samples are better. People often ask me, how many mini forceps bites do you take with cholangioscopy? And I tell them as many as I need to make a diagnosis, and as many as I need to feel confident that I'm making a diagnosis. If I can very rapidly or readily target with pediatric forceps, for example, and I know I'm getting up to the stricture and I'm taking huge bites, maybe that's someone I'll only take 3 or 4 SPY bites. I've taken up to 16 on one patient before when they've had a false negative sample before. So do whatever it takes to establish a diagnosis. My general approach is cholangioscopy on day 1, unless there's a clinical contraindication. Some of my mentors in the field have talked about how when you get a negative sample without doing cholangioscopy, you really don't know what to expect. How high is your pretest probability? Whereas if you get a good visual assessment that the lesion is malignant, and then you get a false negative, that will completely change your approach to how quickly to bring the patient back, how to advise them following the procedure. So I found it in my practice to be beneficial. It has to be balanced against your endoscopy unit, your technical, experience, the cost of performing cholangioscopy. So there's a lot of things to consider. It's not a slam dunk for everybody. This is something that I feel has been a paradigm change in our community in the last 5 years. I see more people going in this direction. It needs to be individualized. Jen gave a nice talk on this in the cholangioscopy pancreatoscopy 101. There's various established criteria for how to detect malignancy, Monaco CRM, Mendoza. In general, I try to look at the stricture that I have in front of me and think about features like tortuous, irregularly branched vessels. When you see those vessels, it's very characteristic that there's a cancer in that stricture. Villiform projections, and the intraductal mass that I demonstrated earlier. This was actually a stricture from Sean's case. That's why it's not a video. It's just a still picture. And you can see vasculature. You can see an infiltrative stricture here. One of the reasons I point out this specific case is all of my other samples were negative, but cholangioscopy-directed forceps did establish a diagnosis here. What are the challenges in establishing a diagnosis for hilar strictures? We've talked about it a little bit over the course. And I think CRM might have mentioned it. Carlos mentioned it on the call when he was doing a case yesterday. There's substantial inter-observer variability, even amongst the world experts, about what constitutes a malignant stricture. There's variability in experience and expertise in calling out what's a tortuous, irregular branched vessel. Particularly, I see a lot of, when I read people's cholangioscopy notes, I often note that there's a lack of the language that's used appropriately to describe what's a high-risk lesion. And then the difficulty with establishing a diagnosis, even when you have a high pretest probability, I think these are the ones that really cause me to lose a lot of sleep. I pass a cholangioscope into the duct, and I feel this is a cancer. It meets all of my criteria. And yet I take biopsies and I still can't establish a diagnosis. And I want to admit that this happens to all of us, whether we want to admit it out loud or not. People are like, oh, you do a lot of this. It must not happen to you. That's not at all true. So you guys can all forgive yourselves. It's going to happen. This is part of life. The things that I think we can change, we can't change that cholangiocarcinoma is desmoplastic. That's often paucicellular, that the malignant cells exist in skip areas, often outside of the bile duct. But perhaps we can improve devices that will help us get there? And could we use something that helps us be better as examiners to really get to a better, earlier diagnosis? And AI is everywhere. I was at a leadership talk, I think 2 years ago now, where the keynote speaker was somebody from Wall Street, and they were talking about the fear of in all industries of AI. And then they used this quote, which was, "You won't lose your job to AI, but you may lose your job to someone who's not scared of AI." And I try to remember that. And I'm as anti-technology as anybody, and I've tried to kind of go the other direction, just keeping this in mind. So Ryan is an author on this. I've been very impressed with their group, with Neil Maria as someone who's an innovator in AI in multiple spaces in endoscopy. But they developed this really fascinating convolutional neural network. They trained with 2.4 million still imaging. Neil's story about this, like sitting in his basement and uploading video for an entire summer, is pretty remarkable. If you guys haven't heard it, I'd really want you to do that. They used an occlusion block heat map analysis to evaluate for malignant features, and they subsequently tested this model against a multi-center cholangioscopy videos. And I'll show, this is directly from their article. You can see there's a bar at the top here. You guys can see my mouse. You cannot see my mouse. There's a bar here which indicates how likely the stricture is malignant. So the first was benign, and this is a clearly malignant stricture. And you can see the red lighting up, telling you that you've reached the threshold of enough malignant features to count this as a malignant stricture. So really a fascinating approach here. And you also note that this is not, we'll have one more slide just looking at their results here. The sensitivity and the negative predictive value really outperforms traditional mechanisms of sampling. For all AI, I think this is something that we should keep in mind, that the more still images, the longer the video recording, the better accuracy. So AI will not substitute for a poorly performed cholangioscopic examination. In their analysis, the frond-like mucosa and papillary projections were the most frequent image predicting a malignant stricture. And then they also presented some really interesting stuff at DDW, and expect more papers coming from this group, extending this analysis prospectively. I know I've sent Neil a couple of clips over email since we've connected, and asked him to kind of plug my video into his algorithm to see what things look like. And I'm as someone who does a lot of cholangioscopy, I'm really excited to see where this goes. So this model is looking at cancer or not cancer without where to biopsy. In contrast, and I think Jen showed this, but for those who weren't there, this is from CRM, Carlos, and this is more of a biopsy here, more of an AI, the GI genius type of mentality of, hey, look here. And you can see where there's malignant features, that would be the site to biopsy. So could this help? And I hate to use the term more novice cholangioscopists, because I think we're all pretty humbled in cholangioscopy. You know it's a cancer, you can't get a diagnosis. So could this help in the future? I think it absolutely could. There's a lot of promise to AI. It's humbling to think how much many of us perform cholangioscopy, and yet we still get false negatives. So I think we should always be open to things that can help, any tools that can make us better. For the first type of AI that, like, yes, this is cancer just based on visual assessment, I kind of go back and forth with what's the value proposition of diagnosing a cancer without histology. These are patients who are unlikely to get chemotherapy and other therapies based on a visual assessment at this time. You can imagine the societal and medical legal implications of something like that. At the same time, in working with our surgeons, if you're close to considering, if the patient is otherwise surgically resectable, and maybe this could push somebody over and say, yeah, very likely a cancer, maybe there's a gray area where there's some value there. Cost, availability, generalizability are questions that we need to answer as a field. Is the display distracting? You want to make sure when I look at it, if there's things lighting up in my face, it might not be the most appealing way to perform a cholangioscopy examination. It's got to be real time. And any of these programs have to be something that we can look at right then. These tools are adjunctive. They will not replace the need for appropriate cholangioscopy skills, and more to come. I'm going to kind of quickly go through a few of the evolving technologies that are out there. Some of the vendors who are here today and represent these companies. I'd encourage you, if you haven't already, talk to the vendors, please do. You can really get a sense, I think Raj and Sachin said this, of what we're all going to be holding in a couple of years. Understanding the working channel of a client. This is something at my hands-on station the other day. We spent time kind of going through so what's available. I always put these as blanks here because I haven't gotten answers yet on how many units have been shipped from the other companies, but there's a lot of excitement, and I think some competition in this market will lead to a lot of good things for our patients. This is just an OG slide. I always highlight my dad as an interventional gastroenterologist, and this is him doing his first spyglass procedure many years ago and how happy he was. This technology has been really meaningful to me in my career. As I mentioned, this is a cholangioscopy inside of an occluded metal stent prior to biliary RFA, and kind of what Carlos was demonstrating yesterday, how much more wide open it can be after. And we've all been in the dreaded situation where there's a migrated plastic stent, and we go through our algorithm of what to do next. And I found cholangioscopy to be a tremendous rescue. You can see kind of blindly passing a wire that goes through, and you're like, yes, we're all good. We're going to get that stent out today. So this is really a tremendous technology. This is a homage to Raj Shah. I put this up as kind of a joke at DDW because it's me holding this, but it's Raj Shah's video. And it's the wonderful things that Colorado has brought to all of us. So the magic of this cholangioscope is how big the working channel is, and the optics, and how ergonomically it can be very successful in the future. So what does technology have to offer? What do I look forward to in the next 5 years? Absolutely better optics. We need that, and I think all of the companies are sprinting towards that finish line. Many are offering different scope sizes with better maneuverability. They often bill it for pancreatoscopy, but I'm really excited to be able to drive in different areas of the intrahepatics into cystic duct. I think the sky is the limit there. We talked about larger working channels, not just for EHL, but better biopsy forceps. Better accessories. So can we have a rotatable device? Can we have a dilation? Can we offer RFA? Can we offer cryo? I think there's really a lot that's coming in this field. Real-time case review. Can we broadcast to experts around the country and around the world and share data in real time to help our patients? And my summary slide, just a couple key points. I know there's a lot to go through today and a lot of information, so I just want to kind of come to a couple key points you guys can take home. Avoid F&B of the primary lesion. Be aware of the different devices that are out there for intraductal sampling. Consider cholangioscopy on index procedure, and I would be really happy to engage in any discussion from others who feel maybe similarly or differently. Be aware that AI and better technology is on the horizon. And then my last little teaching is that advanced endoscopy is often looked at as this type of person or individual or field. But in fact, and if you've been listening the last few days, it is more this type of field where you're sitting and considering and thinking through everything. And with that, thank you guys. I really appreciate your time.
Dr. Singler, that was fantastic. Honor to introduce our next speaker is Dr. Ryan Law, joining us from Mayo Rochester. I think everyone's learned something, especially of the trainees, something from Dr. Law along their way. So thank you, Ryan, for giving us this talk.
Thanks for having me. So over the next few minutes, it's my job to defend the position of persisting pre-cutting or repeating ERCP in the setting of a difficult biliary cannulation. So as we've seen, Dr. Barkan discussed, consistent, efficient, safe cannulation is one of, if not the most important ERCP skill to try and master. Despite that, and even in expert hands, primary biliary cannulation fails in 5 to 15% of cases. We do know that skill level increases with procedural experience. So hopefully for all of us, our cannulation rates continue to improve. Improvement, as I stated to the fellows the other day, is really a never-ending skill. You can always get better. You can always pick up new techniques and new skills. In the setting of failed primary biliary cannulation, we really have 3 ERCP-based options. We can kind of continue with conventional ERCP techniques, We can employ pre-cut sphincterotomy or fistulotomy for access, or we can bail for the day, bring the patient back, reattempt in the near future. What I would say is that, this situation, because it arises at up to 15% of cases, it's important two things: that adequate consent is obtained from the patient discussing, the risk of pancreatitis, the risk of complications in general, but also to ensure that if you're going to move towards advanced maneuvers in ERCP or even therapeutic EUS, you have to have a solid indication. And you have to make sure that moving forward in those situations is the right thing for the patient. It's also at this stage that I think you need to be thinking, if you haven't already, about how you're going to manage the risk for post-ERCP pancreatitis. Are you already intraprocedurally giving, fluid to the patient at a reasonable volume? Have you given rectal diclofenac or rectal indomethacin? Is your plan to place a pancreatic stent if you have access? That, at this point, needs to be part of the algorithm and needs to be part of your thought process. So when we think of persisting, my approach is generally there's no harm in persisting if really two conditions are met. The papilla remains free of any significant traumas. You don't have much edema, you haven't gotten into any bleeding, you haven't turned the major papilla into a hamburger patty. It's totally fine to go forward. And the other thing is that you're going to make some appreciable change to your approach. Are you going to change your guide wire? Are you going to change to a cannula or a tapered tip sphincterotome? Or are you going to utilize or maybe intentionally gain pancreatic duct access? All of these things really should be considered. But what I would say is there's no approach to just continuing to beat your head against the wall and do the exact same thing over and over and over. The biggest area where I think we can have success is probably with double guide wire technique. As Dr. Barkin showed, the ESG guidelines from 2016 are still very relevant, and they do suggest using a pancreatic guide wire assisted cannulation to the bile duct if you get repeated unintentional access. The 2 points I would make is sometimes you may want to pursue intentional access to the pancreatic duct if for some reason you think that will be straightforward and allow you to get into the bile duct. And then the second thing that I think kind of harkens back to the prior slide is that if you're going to go down this road, this patient, in my opinion, mandates a pancreatic duct stent either prior to additional interventions with a second guide wire or at the end of the procedure. And that's really up to the endoscopist. We know that there's very good data to suggest that double guide wire technique works. There's a multi-center French study, 142 patients who were randomized either to early double guide wire or just repeated single guide wire attempts. And the primary outcome was selective common duct cannulation within 10 minutes. Technical success was 84% in the double guide wire cohort and only 50% in the single guide wire cohort, with an improvement in time to access to the bile duct by 4 minutes. Interestingly, and this kind of goes back to the maybe the ambiguity of the data, there was no increased rate of post-ERCP pancreatitis in the double guide wire cohort. I'm a big believer that there isn't a signal there, though there has been some data to show that it is higher risk for pancreatitis when you use a double guide wire. The next approach is pre-cut. Fistulotomy or sphincterotomy, you've seen that demonstrated over the past couple of days, both in talks and in practice. Are you going to do these over a guide wire, over a stent, freehand? There's a lot of data suggesting that fistulotomy and sphincterotomy both have nearly equivalent rates of cannulation and technical success. And perhaps there is a signal suggesting a lower rate of pancreatitis if you use a suprapapillary fistulotomy approach. But this is largely endoscopist preference and comfort, in my opinion. Looking at data, a meta-analysis of 5 randomized trials, including over 500 patients, showed that early movement to pre-cut is the preferred approach. This study included both fistulotomy and sphincterotomy techniques, and it showed an increased odds for cannulation and a significant reduction in pancreatitis. So while the approach may be personal preference, what I would say is that if you think you're heading in this direction, the data would suggest the earlier the better. The final option is repeat the procedure. As Dr. Barkin talked about, I couldn't agree with him more. I love this quote by Heraclitus. No, I did not know who Heraclitus was prior to finding this quote, so I'm not an expert in Greek mythology or Greek philosophy, but his quote is that no man ever steps in the same river twice, for it's not the same river and he's not the same man. And I think that applies to this in the sense that very often, when the patient comes back the second time, number one, if it's a patient who was initially done at your center, you know what didn't work the first time. You know what you did the first time, and you can make adjustments based on that. And then in terms of the patient, now the patient no longer has an edematous papilla, no longer has any trauma from your prior attempt, and your chances of getting into the bile duct are exceptionally high. Going back to 1999 up until 2022, there's 10 studies with a pooled success rate of nearly 80% using standard and advanced cannulation maneuvers without EUS. That's an incredibly high rate and something that we should realize, this may be the best approach for our patients. The risk profile in the follow-up ERCP is really no different than the risk of the index ERCP. At present, there is really no standardization in terms of when to repeat that second ERCP, though I would say you just have to think, common sense in terms of clinical indication in the patient. If this is a patient who, has a rising bilirubin, maybe a rising white count, isn't yet febrile and still looks okay, that's somebody you're going to want to do pretty early versus a patient who has a stone in the duct but is otherwise completely stable and asymptomatic. The other thing I would point out is that patients may require transfer at this point. It's okay to transfer a patient to a different center. If you've exhausted all of your opportunities at your center, you're not comfortable keeping the patient there for the repeat procedure, transfer and a reassessment elsewhere is completely appropriate. And then the final thing I would mention, as this is a debate, is simply things related to EUS biliary drainage. First and foremost, this is not available at every center. This is not available at most centers. It's available at specialized centers with a lot of expertise. In comparison to ERCP, where perhaps an adverse event of pancreatitis is generally mild, adverse events in the setting of EUS-guided approaches are generally a bit more involved. So that's something to consider. This is a study out of GIE recently, which showed an overall adverse event rate, including choledochoduodenostomy, hepatogastrostomy, antegrade therapy, and rendezvous of 14%. This is almost 8,000 patients, including 155 studies. So that's a substantial number. Also, not to be outdone by a reintervention rate of 16%. So that needs to be considered in your algorithm about what you're going to do on a patient-by-patient basis. In conclusion, I would say that in cases of difficult primary biliary cannulation, there's multiple options which are likely to be successful prior to pursuing EUS-guided biliary drainage. We've shown that the double guide wire technique, pre-cut sphincterotomy, fistulotomy approaches have very, very high success rates in this setting with an acceptable risk profile. We've demonstrated that EUS approaches are not without risk, both in immediate adverse events and the need for reintervention. And I would finally say that the approach to this situation of difficult biliary cannulation ultimately should be tailored to the patient, but also the endoscopist. What's your comfort level? Where are you going to have greater success in helping this patient? And that really should kind of take center stage in this discussion. Thank you.
Okay, to provide us a rebuttal, we are once again going to welcome up to the stage Dr. Hiro Izuyama, joining us all the way from Tokyo.
Thank you, Chairman, for the introduction. This is a debate session. So we should know about status of the ES-guided biliary drainage. So recently we so-called ESBDA. Discuss about the which is better. So now. So this is a guideline about technical guideline about ESBDA. We published 2019, 6 years ago. So in this guideline, the indication is a salvage for failed or difficult ERCP. And kind of the ESBDA is an extrahepatic approach and intrahepatic approach. This is our data, the ESBDA in the university. The 95% intrahepatic approach. It is this approach has a very wide indications. Instead, on the other hand, so extrahepatic approach is CDS, very only 2%. So it is most of the cases failed cannulation. So this is a comparison with the ERC bile duct drainage from the ESBDS side. The advantage is no pancreatitis. And I think the easier access, puncture the bile duct, especially the common bile duct is easier than cannulation. So this advantage is still difficult procedure. Many endoscopists think so, but I don't think so. Possible severe complications, perforation, bleeding, and leakage. Then important point is so technical feasibility of the ESBDA and also safety. And ERCP can perform the many procedures, so stone management, stricture management, and intra-bile duct examinations. These we can perform as trans-escal procedures. This is our recent review of the ESBDA. The technical and the clinical success is also comparable, the ESBDA and ERCP. And it is very important thing. So acceptable adverse event rate, and especially no pancreatitis. So continuous transpapillary procedure cannot avoid the post-ERCP pancreatitis permanently. So, but by your transmural approach, we can avoid pancreatitis. This is an incidence of the adverse event in our university. So I moved to the, sorry, in some Japanese, to the Juntendo University 2017. At that time, that are very high, but so dramatically down. And the recent our complication rate is only 5%. Because we have many good skills and devices. This is a CDS. We performed a prospective multicenter study. We performed the ESCDS as a primary drainage method. At that time, we puncture the common bile duct and place free covered Wolflex. It is, I think that this is a very feasible, the high success rate and acceptable adverse event rate. Recently, the CDS with hot access, it is a real, actually 5-minute procedure. But now, this procedure is not available in Japan, but we performed a clinical trial some years ago. So I think it is very easy to access to the common bile duct without any complication, especially the post-ERCP pancreatitis. This is a Korean study. They use all-in-one device for the ESBD. So from their RCT, the technical feasibility is almost the same, but superior in center patency, patient QOL adverse event in ESBD. So then if we have a very good equipment, that we can perform the ESBD very safely. So I want to introduce some development of the devices. Firstly, I want to introduce a new scope from the Fujifilm, named the EG740UT. So I and the team of the Fujifilm developed this scope. This scope can have this very small head and a very good angulation and a guide wire locking system. And we changed the location of the CCD camera. So basically, the CCTV camera located beside the elevator. But a new model, the behind the elevator, we can see the puncture point very easily. So using this scope that we compare with the previous scope, 580, the shortened procedure and the fluoroscopy time because this is so very a dedicated scope for the interventional areas. Actually, the puncture ability very difficult. So 740 so can puncture the very wide area. So according to the scope, the puncture configuration is much different. So Olympus scope, 580 and 740. So it both B2 puncture and B3 puncture. So it is influence on the subsequent procedures. This is actual puncture VTR. Upper one is an old type scope, but still it is very good. But the lower, that's a new scope, almost perpendicularly puncturing. And also we can see the puncture point easily. So it is beneficial to perform the stent deployment. But using the Fuji scope, sometimes we should think about some issue. So the left side is Olympus, right side is a Fuji scope. Fuji scope, during the procedure, we attach the gastric wall to the liver and the puncturing, stent placement. But after that, gastric wall will return to the original position. We already checked this phenomenon by measuring the distance between stomach and liver, before and after. So before and after, so after relatively shorter, but not significant. So then we think the gastric wall will return to the original position, especially using the Fuji scope because very long distance between liver and stomach. So then we use a very long stent. We use also modified geoball, only 1 cm kept uncovered in a hepatic site. So no migration occurred, but the median intragastric stent length is 54 millimeter. So longer is safer in a stomach portion, I think. But sometimes we encounter the very difficult situation, risky situation. At that time, we have the many tips for the anchoring of the stent. So one is anchoring stent technique, and the other one is a clip flap technique. So clipping at the stent body make a new flap. It is also effective. But recently we have a very good stent named the Swing Stopper. I and Team Medical developed this stent. This stent has anchoring portion. It is work as a stopper. So and hepatic site is 15 millimeter kept uncovered. After introduction of this stent, no migration occurred. So it is a very safe stent. So and it is available in Japan. And the other good equipment is a Tornas drill dilator. So maybe so this equipment is get FDA approval some months ago. So it is a very effective tool to dilate puncture route. This is our recent HGS for the B2 puncture with a new scope, 740 UT from Fujifilm. Almost a perpendicular puncture for the B2 and the pre-Caesar configuration of the scope. And the guide wire manipulation is very easy. So because the B2 to the CBD, very easy to pass higher. So and using the drill dilator and additional balloon dilation, bile duct wall, liver parenchyma, and gastric wall. Sorry, bile duct wall and the gastric wall and the liver parenchyma. Finally, insertion of the spring stomper stent. The highlighted area is uncovered. So we located uncovered portion in the bile duct, and the liver parenchyma and the stomach portion is fully covered. And this is a very good fluoroscopic image by Fujifilm, and easy to see the puncture point, and easy to deploy the stent. This is a recent procedure. And to minimize the complication, the leakage. So segmental dilation and the minimum dilation is very required. They're very important. So especially in plastic stent insertion, so remaining the non-dilation area is very beneficial to avoid the leakage. And the bile aspiration during the procedure also beneficial for reduction of the incidence of the peritonitis. Sometimes it's very difficult to puncture the bile duct, non-dilation bile duct. Can you see the bile duct? So very small, but we can succeed to puncture with a 19 gauge needle. But this time, very difficult to insert a wire. So then take over to me. So can you see the puncture point? Very small bile duct, but we can puncture with a 19 gauge because we have many training of the PTBD. So then we can puncture. Finally, we succeeded with a 90 gauge needle and insertion of the auto-5 wire and drill direct additional balloon dilation. And double guide wire technique is a very safer way for the difficult case. Now, finally, we successfully placement of the plastic stent, double pigtail, like ring. So we so-called ring placement method. And the next one is trans-esca procedures. So the CBD stone in a surgical altered anatomy case. So we firstly place a stent, and 1 week later, insertion of the guide wire beside the stent. And we employ the double wire technique. Then dilation of the papilla, EPLBD, 12 millimeter in the diameter. And finally, we can push out the stones. And also on the right side, we place multiple plastic stent for the anastomotic stricture. So after the dilation of the insertion route, we can insert POCS asparagus very easy. We can perform the stone crush procedure and also examination of the stricture portion. And so checking this stricture is benign or malignant by target biopsy. So we can perform the many various procedure as a trans-esca procedure. This is my conclusion slide. So ESBD, technical feasibility, currently okay. But it's according to the device or endoscopist expertise. Safety, recently acceptable complication rate, and no pancreatitis is also a benefit of this procedure. Recently, many good devices and tips are possible to avoid severe complications. And the trans-esca procedures, stone management, stricture management, and intra-bile duct examination is okay. So then, this is my opinion. The era of ESBDA has arrived. Thank you very much for your kind attention.
I think it goes without saying that everyone was impressed with your talk. So, and please join us, Dr. Izuyama, and we're going to open up the discussion for our Q&A and make some comments from the panel. Feel free to step up to the microphone, or we can also answer some questions from the prompt. Oh, hi, Raj.
Hi, good morning. It's an excellent session. Congratulations. I had a question about, and a concern I have related to biliary access. And I think at least here in the US, it seems that there's been a growing enthusiasm for EUS-guided interventions for biliary access, and a concern that I think those of us who have the privilege of training physicians and fellows in ERCP is EUS rendezvous and bile duct drainage going to replace potentially suboptimal or poor techniques of ERCP, and how much do we as a group, as sort of AEF trainers, do we spend on providing quality ERCP basics? And I think any of you could answer that, but I was just curious if we could discuss that.
Both of you weigh in.
Okay,
It's great.
So I couldn't agree with you more. I think the one thing that to me the take home message really should be that as we move forward, I think people are going to perhaps need to be comfortable in both pools. But I don't think that this should be something, even if you're a person who utilizes EUSBD techniques frequently, I don't think that it should be the first step after you spend 3 minutes trying to cannulate the bile duct. I just don't think that that makes sense. I think the reality in these situations is, as an endoscopist, you have to have the insight to say, what do I feel most comfortable doing next to help this patient? And if the answer is, my success rate for going with double guide wire technique in 10 more minutes with ERCP is this high with this low of an adverse event rate, versus, hey, I'm pretty talented with EUS biliary drainage, and my success rate with that and adverse event rate with that, outweighs the benefit of continuing with ERCP. That's likely a patient by patient discussion, not an endoscopist by endoscopist discussion, in my opinion. So, but I do think that going forward, this will become prevalent, but it's upon us as people training the future to say, hey, this is number one, not for the faint of heart. And you see Dr. Isayama's videos and others, and they make it look incredibly easy. What I can tell you is that it doesn't get less stressful case by case. I can tell you that. And as a fellow, that's hard for you to appreciate. It does not get less stressful. There's still stress with each case. You worry about adverse event rates at night. So while it looks attractive, I think there's a lot more to the story and that people need to realize.
Okay, the yes-guided biliary intervention is not so easy for the not expert and endoscopist. But most of the endoscopists recently performed EUS. So then they are so good at observation of the bile duct. So then recently they can puncture the bile duct. The access is okay for the malignant biliary section case, but benign cases, so the non-dilation case is the most. So that at that time, that's very difficult to puncture the bile duct. So so then in our institution, so malignant obstruction case is fellows work, but benign, so relatively seniors work. So most difficult case I perform. So this is some layers we have. But it is not so spreading this procedure for the in the world. In Japan, this is no good certification or education system about this procedure. But each institution, each trainer train their young endoscopist. But recently, it is not enough. So then in Japan, I have a course about ESBD hands-on course. So every year, 40 young endoscopists join our course. The many precise technique we educate. But after back to their hospital, they cannot do themselves only. So then sometimes we call to me. I visited his center and performed the ESBD together. So through these steps, they can perform the ESBD gradually. So difficult to spread sort of dramatically, but gradually, step by step, we can go to the future. So future is bright. I think we can avoid the post-ARCP pancreatitis completely. This is a nightmare for the endoscopist.
Wonderful. Thank you for that. Let's go back to the microphone.
Yeah, excellent talks. And to Raj's point, is there a potential with EUS biliary drainage that we're creating a de-skilling of the ERCP procedure itself over time? If individuals start going more easily towards EUS biliary drainage, then how is it risky to say, or is it potential to say that an individual may not be as comfortable doing an ERCP to perform an intervention for a bile leak? I mean, you're not going to really, are you going to go to USBD for that as well? So I think, should there be some criteria that the society set as a baseline that you must have prior to considering, EUSBD? I'm curious if the panel, in all of the expertise that's up there, would think that what kind of criteria should be in place before you abort ERCP. Granted, we all want to avoid post-ERCP pancreatitis. I don't think there's even enough evidence yet to say that doing EUSBD, for a stone extraction can avoid post-USBD pancreatitis, in that matter. So
Let's just go down the panel. Dr. Singla, you want to weigh in?
I was reflecting on, sorry, it's not a quick answer.
Yeah.
I was reflecting on how different healthcare systems are. And here, most hospitals have EUS, and there's little to no oversight as to who is going to do what on which patient. So I think it's very difficult to enforce really anything that we do. I am concerned about de-skilling as well. I didn't want to belabor that point, but I think all the fourth-year fellows in here really need to get very good at ERCP for the situation that was just mentioned.
Dr. Null?
Yeah, I don't think I can add much more. I think the concerns, sentiments are there as well. I think, but it comes back to the trainers and those who are sort of involved in training young endoscopists coming through. I think the ERCP is the workhorse, and there's no alternative for good technique and optimal skill in that specific case. I think, as Ryan said, those who do EOS biliary drainage, it's not straightforward all the time. The rendezvous technique is finicky. It's frustrating, despite how many you do. But I think this is the natural history of implementation of new techniques. We go through this where there's a concern for de-skilling and that, and it really comes down to the responsibility of those involved in teaching and to make sure that we teach the right way, and that that would be my sort of feeling along the line. Yeah.
Dr. Larkin?
I think we're all repeating the same thing by now, but I think de-skilling is a concern. I think you need to have clear minimum standards, volumes, and performance. With AI available now, everybody should be able to measure their performance as well at some point in time, not just the numbers, but the performance, and decide. And I think that I can tell you right now, if in Canada tomorrow we say, oh yeah, everybody's going to have, in the same setting, if you can't finish the RCP, you switch, etc. We don't have enough people who do therapeutics. We don't have enough cash to pay for all the elements that do this. And I understand and I respect completely the issue of post-USCP pancreatitis, but it's not as though these options are risk-free as well. So I think probably we need good prospective studies, and we need to be very careful, and societies are going to have to decide how to proceed on it.
That is, yeah.
Good night. So actually, we don't have a very good criteria of the endoscopists in Japan, even so. Then each institution decide their own according to their opinion and their expertise. So, but because I think that this procedure is still immature. So no good equipment, even in endoscope, echo endoscope. So ERCP scope is a very dedicated to perform the cannulation. But a ESBD scope Yes, EUS scope, echo scope is for the observation, not for the intervention. So then we should develop the dedicated scope for the ESBD. If we puncture the everywhere the bile duct, so that, it is more easy. So also puncturing needle, the wire, dilators, no dedicated. So then after the maturation of these situation, maybe so ESBD can become as a primary drainage method. So according to the cyst drainage, so previously it is so very difficult and most of the case performed by a surgical approach. But after introduction of the Axios, everybody do that. So it is the same situation in the near future. But this currently, it is an immature procedure, then require the expert hand.
Yeah, the only thing I would add to this is, I do both of these, and for the fellows in the room, these are really flashy procedures. They're really cool, but it is just as cool to navigate an incredibly difficult papilla and have a great ERCP result. So take in mind that that is just as good as doing all these great advancing procedures, but sometimes the old tricks work even better. So to keep that in mind as you're learning this stuff. Dr. Law.
The only point I want to make is to Raj's point is when you think about this, ERCP can't go away. And the reason being in this is that the only part of this that's EUS is access. Everything else is ERCP technique, stent placement, balloon dilation, stone extraction, whatever you're doing. Yes, it's a different format and packaged a little bit differently. The techniques are still the same. Gaining access is the EUS part. Establishing a fistula, something to work through, that's EUS. Everything else is an ERCP technique beyond that.
No, I think, Ryan, this is exactly what I was going to say, is that I think the de-skilling point is valid, but actually someone who's just been doing this for way shorter than a lot of you guys has, I'll tell you that I think that you have to be really good at ERCP to be able to do EUS guided biliary drainage. And then the second point I was gonna, or a question, I guess, or a comment was that I think when you can get to the papilla, meaning you have a normal anatomy or whatever, you're able to get to the biliary orifice. At that point, I don't, in my mind, even though there's a lot of debate, there's very little benefit to doing EUS bile duct drainage over standard ERCP. But the real question is when you can't get to the papilla, what is the panel's thoughts? And I know we're short on time, so I'll just maybe one or two if you can comment on that. When is EUS biliary drainage better than PTBD? When you can't get to the papilla. That's, to my mind, is where EUS biliary drainage comes into picture.
Dr. Knoll, you want to take that one?
Yeah, so we're fortunate in that we do both of those procedures. And I think that's where it gets tailored. I think I can't really answer your question to say that for every situation, the one's better than the other, or the vice versa. I can tell you that if you look at the data, there is head-to-head studies looking at PTBD versus EUS. Again, they're in sort of centers of excellence with special interests in both. And EUS seems to have a better side effect profile with similar sort of technical and clinical success rates. Having said that, there are fundamental differences. A difficult case via percutaneous sort of route, PTBD route, for example, lithotripsy, difficult stricture manipulations, you have a lot more pushability using the PTBD route compared to the US route. And so cases that are really complicated, or where I'm anticipating more than one sort of technical difficulty in the case, I'd rather go the PTBD route, especially where pushability becomes a significant factor. And the other note is that if you look at the data regarding the adverse effects of PTBDs, the commonest complication is just a bile leak around the drain, which is actually not such a big issue. Quality of life, if you're going to leave the drain in there, is an issue. But generally for antegrade intervention or sort of same session intervention where you remove the PTBD same day or the next day, there really isn't much of a difference. But it is individualized, and we need a lot more data to be able to tease out subgroups in that perspective, in my opinion.
Ryan, you want to add a follow-up?
Yeah, just getting back to what Colin was saying, we need to kind of get away from the illusion that percutaneous drainage is like purely risk-free, super easy procedure. That's not always true. In many of these patients where these situations arise, you're talking about a patient with advanced malignancy, there might be ascites. They have the same risk for causing SBP that we do from going across the liver, and there's still risks for bleed. The other thing, which I think is the real 10,000-foot view of this, is conversations with the people in your orbit, with your surgeons, with your oncologists, with your interventional radiologists. I talk to my interventional radiologist probably daily about different cases and what makes the most sense in what situation. So I think that doesn't, having a one-track mind is not great. Have these multidisciplinary discussions and make sure that everybody's on board with the decisions being made, whether it's interventional EUS or percutaneous drainage.
Excellent. Why don't we take one more from the mic, and then we've answered a lot of these questions on the television, but why don't we go one more from you?
Great talks and a great discussion and such an amazing panel. But just adding I love analogies, and I think most of us here are experts in pancreatic biliary work, but we also do a lot of advanced resection work. So putting the hat of advanced resection into looking at this, I think on the advanced resection side, we're pushing the limits to be very natural orifice, respect the anatomy, avoid incisions and altering the anatomy with surgery when it comes to taking large colon polyps, taking early cancers. But then when we come to this discussion on the other side, comparing ERCP and EOS-guided biliary drainage, EOS-guided biliary drainage is more like the surgical option. We are changing the anatomy. So ERCP is the option that respects the anatomy of the bile duct, of the pancreas duct. EOS is like creating a new fistula. So I think it might come down to the same way as we say to a gastroenterologist who sees a large colon polyp and they're not able to resect it. It's recommended based on all the society guidelines to refer to an expert center where they can evaluate it and give that patient an opportunity for incisionless resection, whether it's EMR, ESD, etc. The same should probably apply to ERCP. So if you are in a smaller hospital and you do 100 ERCPs a year, probably it's a good idea if that ERCP did not work and you did your due diligence and tried, is to refer to a tertiary referral center where they have the expertise in both. And I think at that point, those experts can make the decision, should I retry ERCP, which I would think most of us typically do, unless there is no way to access the ampulla, versus should I just do upfront EOS-guided biliary drainage? And I wonder what's yours, like the panel's thought about this approach, that if someone tried, it doesn't hurt to either call another colleague to try ERCP or refer to a tertiary referral center, the same way we deal with polyps and early cancers and lesions like that.
Can I add to that question? And I think brevity to the answer would be great. The question is, community physician doing 25, 50 ERCPs a year, they fail. What do you recommend to them? Be very brief in your answer. Be great. Thank you.
Yeah, go for it.
Refer to a tertiary center at
But
that
a lot
point.
of them don't have, a lot of them work in hospital systems where they don't necessarily want to send it to University of Colorado, to Henry Ford. They might be, their hands may be tied related to insurance things or hospital administration saying we keep these patients in our system. What do you tell those guys?
Can I ask a question? Do you think that that person will be, if they do so few ERCPs, will be that expertly trained in US? Probably not. In general, but US is off any type. Okay, I understand.
Pre-cut or not pre-cut, that type of question. Is that what you're asking, Raj? Because I think it will depend on what the biliary pathology is. If you have a big dilated intrahepatic system from cancer, for example, I would say contact your local IR if you can't refer to a tertiary care center at that point. But if you have a bile leak, that's a different story. So I don't know. I would have to.
That's great.
I think everything comes back to local expertise. What you have locally is what you have locally. And locally at Mayo Clinic is different than northern Minnesota. So if in that situation, if the only option that exists to keep that patient out of harm's way is to put in a percutaneous drain, then put in a percutaneous drain. It's going to be a patient by patient or institution by institution basis. But I wouldn't say that, there's no role for PTBD, there's no role for repeat ERCP, nothing like that. Put in a drain if that's what you can do to help the patient, keep them out of harm's way, and then figure out a plan after that.
Absolutely. Dr. Binmoller, you wanted to ask-
Hi there. I couldn't resist after that beautiful comment that was just made by Mumid. I think, hopefully I'm pronouncing your name right, because it resonates so much with me in terms of, well, what inspired me to develop the LAMS. It wasn't to enable pseudocyst drainage or wand drainage. We could do that actually previously. It wasn't to drain the bile duct. Of course, ERCP could accomplish that, PTCD as well, but it was to preserve the gallbladder. So that was what inspired me. And it was to preserve an organ that our Creator gave us and that I felt was too often unnecessarily being sacrificed for a problem like stones that actually could be treated endoscopically, and we could preserve the natural, relatively speaking, the natural route of drainage into the duodenum. So I just wanted to say that with the bile duct, I also believe that we should preserve that natural route of drainage whenever possible through the bile duct. And what has disappointed me about LAMS is that when you remove LAMS, the tract almost always closes. And that was a huge disappointment because my assumption was that if you leave the LAMS in place for a prolonged period of time, let's say 6 months, it would stay open, the fistula would stay open. And I've realized that's not the case. So that is a problem as you think about LAMS as a long-term solution. You've got the problem of overgrowth and ingrowth. We've seen that all. We've heard about the bleeding complication. And if you remove the LAMS, then the fistula closes. The natural orifice pathways don't close.
Thank you. And this is an incredible, lively discussion. I feel like we could spend a whole day in this debate. A lot of these questions have been answered, but I do want to give Dr. Shaw a moment. He wanted to say some words as well, but do we still, you want me to keep going? Okay, never mind. Let's answer another one. I did see one for Dr. Singla down below regarding cholangioscopy. I thought it was an excellent question, actually. And it really highlights the kind of what you were referring to with AI and what we've been discussing about, is larger bites the issue with cholangioscopy, or is it more the targeting of bites? And, or is it quality or is it quantity? That's really what it is, I think.
It's a great question. I would say it's both. The size of the forceps matters a great deal. That's why pediatric forceps, even without targeting, can often give you a diagnosis. At the same time, the biopsy here, and especially again for all of us, we're all novices in the field. So for all of us to say this is the highest risk point is also important. And then better technology to help no matter what. You watch these beautiful videos of the forceps getting every side of the bile duct. It's very difficult to do that in real practice. So if there are better forceps that can help us target the area that we now know is abnormal, that would also be a game changer. So I think it's all of those things.
Yeah, I 100% agree. So there's another quick question on EDGE. And discuss, and we can open this up to everyone, but EDGE seems to be becoming more common over time in our gastric bypass patients. And there seems to be a move away from anatomy preserving techniques, being the double balloon assisted. And the question is, why do you think that is? And is that right to do? It's a really good question. It's both, the objective and the subjective component of this. Ryan, do you want to?
Sure. So I think the move away is because the alternative options are limited. So double balloon assisted ERCP in terms of successfully getting to the papilla and then successfully cannulating is exceptionally low, much lower than what I would say is published in the literature. Lap assisted ERCP has always been limited by most likely scheduling, trying to orient gastroenterology and surgical schedules to allow for that, though there is still, I think, a limited role. It just takes a lot of kind of pre-procedure effort. In terms of EDGE, I probably am a person who has actually moved away from EDGE, particularly single-stage EDGE, just for the cases where a risk of dislodging that new fistula you've created. I think that to me, the role of EDGE is in the patient who has a need for either a clinical need for sphincterotomy for sure, or a patient who has a biliary stricture or pancreatic head mass that needs assessment. I think, we see a lot of patients at our institution who come in with Roux-en-Y bypass with a single stone in the bile duct. We've moved away from EDGE in that situation. We have done rendezvous with IR, placement of a wire, balloon dilate the papilla, remove the stone, and everybody goes home. We've done cases where we have our radiologist place a percutaneous drain. 6 weeks later, we upsize to a peel-away sheath, and then go with a cholangioscope through the skin, break up the stone, push out the fragments, and leave nothing. But EDGE is not risk-free, and I think there's a lot of nuance with it. So to me, EDGE, the real role is when you're probably going to do EUS or there's something you have to intervene on the papilla.
Excellent. You had a question?
Yeah. Could I had two questions. One for Dr. Knoll, since we have a surgical opinion here, is for a lot of these altered anatomy cases, on the surgical side, what's kind of being done in the thought process of kind of either trying to standardize some of these limbs or document how long these limbs may be? As someone that does, altered anatomy ERCPs, and then it's also is altering the anatomy, since we are able to do more kind of, maybe what can be done on the surgical side. I know it's difficult in some of those cases in that process. And the other thing I wanted to just ask about too, if we have time, is the double wire technique for new trainees. When you get into the PD, kind of what is your actual process when you're learning? Do you pull the wire back or do you just go back in a second time? So if I could get comments on both of those, that'd be great.
So fantastic question. Again, because I do both, I end up frustrating myself. So the bottom line is that, the perfect world, we should be documenting it. The reality is that, number one, your bowel, sort of outside of peristalsis, the lengths are very different to the lengths post and when you've got a functional bowel with peristalsis. Number two, as soon as you do alter the anatomy, the limb length naturally through gravity sort of elongates, not much, but it does get longer. I have, I'm probably not very good at it, because when I do predict my length and I subsequently go for one or another reason with endoscopy, it always seems a lot longer than what I anticipated and what I'd reported. And I can imagine that because endoscopy is done by a different discipline here, there's probably not the appreciation of the significant difference it makes, the lib length. So probably surgeons, and definitely myself, I still don't appreciate it and document it correctly. But I don't think one appreciates enough how important that is. But it's not any limb length. It's the angle of the anastomosis, whether it's colic, anticolic, whether it's retrogastric, whatever the reason. We don't take enough time to realize the implications of this in subsequent sort of biliary access. Coming to your second point, I'd love to hear from the rest of them, but the data, in my opinion, supports, if you look at the pancreatitis risk, it's after 2 cannulations of the pancreatic duct. You still, if you haven't caused enough trauma by just cannulating guide wire the pancreatic duct once, in my opinion, it depends really if I've gone past the cornea or not as well. But if I haven't gone past, because hopefully you recognize it quite early, unlike my case yesterday, recognize it quite early that you've cannulated the biliary, the pancreatic duct. You do not increase the risk of pancreatitis by having a second attempt if you had it cannulated. So you do not have to remove it. Leave it there. If you look at double guide technique versus your sort of primary cannulation, it's higher primary cannulation. The double guide technique helps and it assists by bouncing off, but you still have the best chance on your primary cannulation. So my practice is, if I've gone in once, unless I really predict that it's going to be difficult, I leave it there. Bring it back. I have a second attempt. Second attempt goes in there. I leave it there, because now my third attempt, the data supports increased risk of pancreatitis, and I utilize it on that basis. But it is, again, case to case, and I'd love to hear from the rest of the panel. It's probably different.
Yeah, I'm going to quote Ryan quoting the Greek mythologist about the river's never the same for 2 different men. And in the same way, I don't think 2 papillas are the same, and I don't think two endoscopists are the same. So if I use pure wire cannulation predominantly, and if I just use a wire and it flies into the pancreatic duct, I will be more likely to do what Colin said and pull that wire back and try to redirect. Whereas if the papilla is tiny, it's in the inside of a diverticulum, I've been trying to even just get my tome to the papilla for 20 minutes, and I finally get a wire in, it's in the PD, I'm going to take that wire and I'm going to do double wire at that point. So I think it really depends. The other part about endoscopic data is if you give me the tool that I'm best at, my success rate is higher. And so I struggle when people say, well, the data is, no disrespect to you, Colin, but when the data says one thing, if you're forcing a hammer to act as, a different tool, then their success rate is going to be lower. So I'm always cautious with that.
Wonderful.
Maybe
Go ahead.
The other aspect of the question was also pancreatic stent insertion. And I think for us, usually we'll leave the wires and try and do everything with the bile duct, and then at the end come and put in pancreatic stent. It's a trade-off, obviously, because sometimes things happen during the procedure and you fall out and so on. But I think it's harder for the fellows, particularly, to be able to maneuver with pancreatic stent in place than with just a pancreatic guide wire. So I think that's what we would do. But you have to be careful, and it is a trade-off.
Yeah.
So I have an additional comment. So double wire technique is so it is feasible and get a higher success rate of the biliary cannulation. But this technique is difficult for the young endoscopist. So then recently in Japan, it is there is one dedicated catheter, double lumen catheter for the double wire access. So the second wire, the 3 millimeter, so distal from the tip, this is the access direction. Direction is different from the initial wire. So and easy to perform the double wire technique. It is only a beginning, but it is a dedicated device. So if there all the doctor agree to the double wire technique is effective, we should develop the dedicated devices for this procedure.
Thank you all for this really lively discussion. Let's give everyone a round of applause for this. This was great. Real quickly before we break for lunch, Dr. Shaw had something to say, and then we'll get you all off to lunch.
Moderation. Thank you.
Thank you so much for your talks are fantastic. Yeah, we can stay. And if for all these other questions that are coming that if you didn't get a chance to ask us, we can sure enough talk to you at lunch. Please feel free.
Thank you, guys. That was fantastic. I wish we could have kept going there. Want to give you a few updates from the cases yesterday. This is courtesy of our advanced endoscopy fellow, Tom, and also Michael as well. So the EPOM patient, there was no leak on esophagram, and they're discharging home. The GPOM patient, no leak on CT with oral contrast, discharging home. The EMR with possible perforation had an unremarkable CT, doing well clinically, without a white count and going home. The EOS coil embolization, no overt bleeding. The EDGE stage 2 at the end of the day, doing well. Drain output from percutaneous drain has dropped significantly. Good work. And the TOR patient, if I'm pronouncing that correctly, doing well and being discharged. So thanks for those updates. It's nice to have a positive update like that. I did write at 5 a.m., so I apologize. And you'll be able to tell that I did not use AI for this. This is the interventional ways that amaze. And this is a tribute to all of our excellent faculty that were involved with RMIE. Here it goes. Deloy guided behind the camera in the control room, Wani's esophagus preservation expertise, and wrapping up the afternoon live feed. Bilal, steadfast in case, in room and in good humor in every way, too busy for a social media post. Pocola ran reconnaissance and smartly eased our day. Nickum remained with a smile, yet diligent for each patient and provider. Bala, within 1 day, learned the ropes for the behind the scene, and Mundowitz ran the urgents so each of us could execute our roles. Enk and Joseph, our AEFs, graciously persevered until the end. Robles Medranda from Ecuador, Cholangioscopy AI and EUS Next Level. Lactakia and AIG colleagues, GJ and 8GS, with ease and mastery. Barkin bringing the latest and greatest for 2025 GI bleeding. Dr. Christie providing reassuring words and confidence in us to roll in our mission. Ben Moeller with leading innovation and dogma from coils, glue, underwater, yet keeping our heads above water. Gabber in-room guidance of third space to leave no trace. Messman resected and incised, bringing skill from all sides. Isiyama's pancreas biliary expertise, carrying subtle, differing opinion yet deliberate guidance. Montminy as our ombudsman, and his cheerful demeanor enhanced the course milieu. Noel from South Africa, bringing a gentle and kind pink biliary approach, begs the question, can he really be a surgeon? Tucker calmly and expertly doing all the right things despite what we thought was well thought out plans. Fan, who ran from the esophagus burn in order to preserve and outlet closure to shed the pounds. Pohl moderated with modesty, challenging faculty by asking the questions we all were thinking. Rex, colon resection mastery, with finesse and agility, remained good-natured despite earfuls of opinion. Singla, bringing broad expert opinion from CCA to SEMS, gallbladders and outlets. Law, good humor with pancreas and biliary expertise, and he kept us all in check. And lastly, Christy Click, the life preserver and rock star to keep us all afloat. Thank you.